Hi there, I'm a Psych NP and I have 24 questions for you on SSRIs. Ready? Let's learn Psych fast. Question 1. Which SSRI is particularly associated with distressing withdrawal symptoms when stopped abruptly? A. Fluoxetine, B. Sertraline, C. Paroxetine, D. Citalopram, or E. Escitalopram? The answer is C. Paroxetine, also called Paxil. So why is the answer paroxetine? Well, it has a relatively short half-life compared to other SSRIs, which means it clears the body quickly. This rapid clearance can contribute to more pronounced withdrawal symptoms when the medication is stopped abruptly. Patients may experience symptoms like dizziness, nausea, headache, insomnia, and what's often described as like an electric shock sensation in the brain, known as brain zaps. It's essential for you, the healthcare provider, to be aware of this when discontinuing or tapering off paroxetine to minimize these withdrawal effects and ensure a smoother transition for your patient. Question 2. Which SSRI has the most prolonged half-life, including its active metabolite? Is it A. sertraline, B. fluoxetine, C. paroxetine, or D. escitalopram? The correct answer is B. fluoxetine. Now why? Well, fluoxetine itself has a relatively long half-life of around 1 to 3 days, but what makes it a particularly notable is its active metabolite, norfluoxetine, which has an even longer half-life, extending up to several weeks in some cases. This combination means that fluoxetine remains in the body for an extended period of time, even after discontinuation. This prolonged presence in the body can be advantageous for some patients as it reduces the risk of withdrawal symptoms during dose changes or medication discontinuation. However, it also means that the effects of fluoxetine persist for a more extended period, which can be a consideration when initiating or adjusting treatment. Question 3. What is the approximate half-life of sertraline's less active metabolite? Is it A. 26 hours, B. 3 to 5 days, C. 7 to 9 days, D. 15 hours, or E. 35 hours? The approximate half-life of sertraline's less active metabolite is 3 to 5 days, which corresponds to option B, which is the correct answer. Now, why is that? Well, sertraline undergoes hepatic metabolism to form its primary metabolite, desmethylsertraline, which is indeed less pharmacologically active component compared to sertraline itself. This metabolite still remains some level of activity, contributing to the overall effects of sertraline in the body. Question 4. Which SSRIs are listed as the most highly bound to plasma proteins? Is it A. paroxetine, citalopram, and fluvoxamine, B. sertraline, fluoxetine, and paroxetine, C. citalopram, escitalopram, and sertraline, D. fluvoxamine, fluoxetine, and citalopram, or is it E. escitalopram, fluoxetine, and sertraline? The correct answer is B. Plasma proteins binding refers to the degree to which the medication attached to the proteins in the bloodstream, primarily albumin and alpha-1 acid glycoprotein. When drugs are highly bound to plasma proteins, they remain in circulation for longer periods, as though they are less likely to be filtered out by the kidneys and excreted from the body. This binding can also affect the distribution and elimination of the drug, influencing its overall pharmacokinetic profile. In the case of sertraline, fluoxetine, and paroxetine, these SSRIs are known to exhibit relatively high levels of plasma protein binding compared to other medications in the class. This characteristic can have implications for factors such as drug interactions and the potential for drug accumulation in patients with impaired kidney function. Understanding the extent of plasma protein binding is crucial for healthcare providers when prescribing SSRIs, as it can impact dosing strategies, the risk of adverse effects, and considerations for patients with comorbidities. Question 5. Which SSRI is noted for having the most marked effects on several of the CYP enzymes? Is it A. fluoxetine, B. paroxetine, C. citalopram, or D. sertraline? The answer is A, fluoxetine. Fluoxetine is known for its potent inhibition of several CYP enzymes, particularly CYP2D6 and CYP2C19. These enzymes are involved in the metabolism of numerous drugs, including antidepressants, antipsychotics, and beta blockers. By inhibiting these enzymes, fluoxetine can alter the pharmacokinetics of co-administered medications, leading to potential adverse effects or reduced efficacy. Question 6. Which SSRI is least likely to complicate treatment due to drug interaction? A, fluoxetine, B, paroxetine, C, citalopram, D, escitalopram, or E, sertraline? The correct answer is E, sertraline. Drug interactions occur when one medication affects the pharmacokinetics or pharmacodynamics of another medication, potentially altering its effectiveness or increasing the risk of adverse effects. Certain SSRIs, due to their pharmacological properties, have a higher likelihood of interacting with other drugs. Specifically, sertraline is considered to have a relatively favorable drug interaction profile compared to some other SSRIs. While no medication is entirely devoid of potential interactions, sertraline is less likely to inhibit or induce cytochrome P450 enzymes specifically, which are responsible for the metabolism of many drugs. Additionally, sertraline has a lower affinity for other receptors such as histaminergic and cholinergic receptors, reducing the likelihood of interactions mediated through these pathways. Question 7. Which enzyme inhibition by fluoxetine and paroxetine may interfere with the efficacy of opiate analogs? Is it A, CYP1A2, B, CYP2D6, C, CYP3A4, or D, CYP2C19? The correct answer here is B, CYP2D6. Fluoxetine and paroxetine are known to inhibit the activity of cytochrome P450 enzyme CYP2D6, which plays a crucial role in the metabolism of many drugs, including opiates. Inhibition of CYP2D6 can lead to reduced metabolism and increased plasma concentrations of opiate analogs, potentially resulting in enhanced and prolonged effects or adverse reactions. Although fluoxetine and paroxetine can inhibit A, C, and D, those options, that is not their primary enzyme involved in the metabolism of opiates. So let's review quickly what the others do so you know why they are wrong. So all four of these are part of the cytochrome P450 enzyme family, primarily found in the liver. CYP1A2 helps break down drugs like rifampin, potentially speeding up the metabolism of medications processed by this enzyme. It's also responsible for processing toxins from tobacco smoke and charbroiled foods, along with substances like caffeine and steroids. Additionally, it plays a key role in metabolizing drugs like theophylline, caffeine, and certain antidepressants. CYP3A4, now that plays a crucial role in the metabolism of the statins, calcium channel blockers, macrolide antibiotics, the erythromycin, clarithromycin. Also does benzodiazepines, antifungal agents, and also antiretroviral drugs like ritonavir. And then there's CYP2C19. Well, that's involved in various drugs, including proton pump inhibitors like your omeprazole, antidepressants, your citalopram, escitalopram, antiplatelet agents like clopidogrel, and then antiepileptic drugs like phenytoin or diazepam. Here's an easy way to remember if cytochrome P450 is acting as an inducer or an inhibitor with the mnemonics CRAP GPs and sickfaces.com. The mnemonic CRAP GPs can be used to easily remember the common CYP450 inducers. You could write these down or take a screenshot. And then there's this one for the CYP450 inhibitors that increase the concentration of drugs metabolized by the CYP450 system. The mnemonic sickfaces.com can be used to easily remember the common CYP inhibitors. Question 8. What proportion of people who respond poorly to one SSRI may respond favorably to another? Is it A, less than 10%, B, approximately 25%, C, around 50%, D, more than 75%, or E, it varies quite widely? The answer is C, around 50%. Just because your patient does not respond to the first SSRI you prescribe does not mean that you should automatically switch to another class like an SNRI or an MAO. Approximately half of those who don't respond favorably to one SSRI may actually find relief with another. This underscores the complexity of individual responses to medications and emphasizes the need for tailored treatment strategies. Question 9. What does the FDA's black box warning for antidepressants specifically relate to? Is it A, risk for liver damage, B, SI thoughts and behavior in children and young adults, C, risk for addiction, or D, increased risk of heart attack? The correct answer is B. So the FDA has issued a black box warning, which are the agency's most serious type of warning that's reserved for situations where there's an evidence of a significant risk associated with medication. In the case of antidepressants, this warning specifically relates to the increased risk of SI thoughts and behavior, particularly in children and young adults. This warning is based on a decades-old analysis of clinical trial data. More recent comprehensive reanalysis data has shown that SI and behavior decreased over time for adults and geriatric patients treated with antidepressants compared to placebo. No differences were found for youth. In adults, reduction in S and attempts occurred through a reduction in depressive symptoms. In all age groups, the severity of depression improved with medication. It is crucial to keep in mind that SSRIs, like all antidepressants, prevent potential unaliving oneself as a result of their primary action, the shortening and prevention of depressive episodes. In clinical practice, a few patients become anxious and agitated when started on an SSRI. The appearance of these symptoms can provoke aggravated SI. So that's why depressed patients should be closely monitored during the maximum risk period, which is the first few days or weeks of starting an SSRI. Now let's go over the other options and why they're incorrect. Option A and C, risk for liver damage or addiction. While liver damage or addiction are potential side effects of some medications, it's not a specific concern addressed by the FDA black box warning for antidepressants. And then option D, increased risk of heart attack. Similarly, while cardiovascular risk may be associated with the medication, the FDA's black box warning for antidepressants pertain to a different safety issue, specifically SI thoughts and behaviors in children and young adults. Question 10. What is the maximum recommended dose of citalopram for patients with hepatic impairment older than 60 years of age, CYP2C19 poor metabolizers? Are those also taking cimetidine? Is it A, 10 milligrams a day, B, 20 milligrams a day, C, 30 milligrams a day, or D, 50 milligrams a day? All right, the answer is B, 20 milligrams a day. So let's dive into this question, dissect why option B, 20 milligrams a day, is the correct answer. The maximum recommended dose of citalopram for a specific patient population, such as those with hepatic impairment, individuals older than 60 years of age, CYP2C19 poor metabolizers, or those that are also taking cimetidine, is indeed 20 milligrams per day. Do you recall a couple of questions ago that mnemonic, crap GPs, and sickfaces.com? Cytochrome P450 can act as an inducer and inhibitor. In this case, cimetidine is part of the sickfaces.com, thus it is a CYP450 inhibitor. It's crucial for healthcare providers to consider these factors to ensure patient safety and optimize therapeutic outcomes. Now let's explore why the other options are incorrect. Option A, 10 milligrams a day. This dose is too conservative and may be insufficient for some patients requiring treatment with citalopram. The maximum recommended dose for the specific patient population is higher. And then options C and D, 30 and 50 milligrams a day. Well, these doses exceed the maximum recommended dose for patients with these specific conditions. And it could lead to a potential increased risk for adverse effects or toxicity. Furthermore, the FDA now recommends no dosage of citalopram to be greater than 40 milligrams. Question 11. Which electrolyte imbalance should be corrected before administering citalopram? Is it A, hyperkalemia, B, hypernatremia, C, hypokalemia, D, hypermagnesia, or E, hyperkalemia? The answer is C, hypokalemia. So before administering citalopram, it's crucial to correct any existing electrolyte imbalance to ensure patient safety and optimize treatment outcomes. But in this case, it's hypokalemia. So the FDA recommends to correct hypokalemia and hypomagnesia before administering citalopram. This is important because citalopram, like other SSRIs, can potentially exacerbate or contribute to electrolyte imbalances, including hypokalemia. So let's correct this and decrease the risk for cardiac arrhythmias and muscle weakness. And here are all of the FDA's recommendations regarding citalopram for your reference. So 20 milligrams a day is the maximum recommended dose for patients with hepatic impairment who are older than 60 years of age or who are CYP2C19 poor metabolizers, or those that are also taking cimetidine, also called Tagamet. Now, the second one is no longer prescribed at doses greater than 40 milligrams a day. Number 3, do not use in patients with congenital long QT syndrome. Next is correct the hypokalemia and hypomagnesia before administering citalopram. And last, monitor electrolytes as clinically indicated. Now let's explore the incorrect options. Option A, hyperkalemia, does not pose a direct contraindication to administering citalopram. However, careful monitoring may be necessary in patients with hyperkalemia, as certain medications can affect potassium levels. Option B, hypernatremia, that may result from dehydration or excessive sodium intake and typically requires correction with fluid management rather than altering medication regimens. Option D, it's hypo, not hyper magnesia. That's the issue here. And then option E, hyperkalemia, that may have various underlying causes and typically requires specific management approaches depending on the etiology. Question 12. Which SSRI is often taken in the morning due to its propensity to cause insomnia? Is it A, sertraline, B, fluoxetine, C, citalopram, D, paroxetine, or E, fluoxetine? The answer is E, fluoxetine. Fluoxetine is often taken in the morning because of its propensity to cause insomnia as a side effect. This timing helps mitigate the risk of disrupting sleep patterns, as taking it earlier in the day allows for the medication's stimulating effects to diminish by bedtime, thus reducing its likelihood of insomnia. The primary effects of SSRIs exert in the area of insomnia and sedation is improved sleep resulting from the treatment of depression and anxiety. However, some, like 25% of people on an SSRI, have trouble sleeping, excessive somnolence or overwhelming fatigue. Fluoxetine is the most likely to cause insomnia, so it is taken in the morning. Sertraline and fluvoxamine are about equally likely to cause insomnia as somnolence, and citalopram and especially paroxetine often cause somnolence. Escitalopram is more likely to interfere with sleep than its isomer sibling, citalopram. Question 13. What is a common side effect of SSRIs related to sleep? Is it A, vivid dreams, B, sleepwalking, C, sleep paralysis, or D, narcolepsy? The correct answer is A. A common side effect of SSRIs is related to sleep, is vivid dreams. Many individuals report experiencing unusually vivid dreams or even nightmares while taking SSRIs, particularly during the initial weeks of treatment. This side effect is typically transient and may diminish over time as the body adjusts to the medication. Other sleep effects of SSRIs include bruxism, restless legs, nocturnal myoclonus, and sweating. Now let's look at the other options of why they are incorrect. B, sleepwalking. While sleepwalking is a sleep-related behavior disorder, it's not a common side effect specifically associated with SSRIs. Sleepwalking is more commonly linked to other factors such as genetics, stress, sleep deprivation, or certain medications. Option C, sleep paralysis. Sleep paralysis is a phenomenon characterized by temporary paralysis of the body upon awakening or falling asleep, often accompanied by hallucinations. This is not a common side effect of SSRIs. And then D, narcolepsy. Well, narcolepsy is a neurological disorder characterized by excessive daytime sleepiness, sudden episodes of sleep attacks, and cataplexy. SSRIs are not commonly associated with the onset or exacerbation of narcolepsy as a side effect related to sleep. Question 14. Which SSRI is associated with seizures more frequently at higher doses? A, sertraline, B, fluoxetine, C, citalopram, D, paroxetine, or E, fluoxetine? The answer is E, fluoxetine. Seizures have been reported in 0.1 to 0.2% of all patients treated with SSRIs, which is similar to other antidepressants. Seizures are more frequent at the highest dose of SSRIs, like a fluoxetine at 100 milligrams a day or higher, than at its standard dose. Therefore, healthcare providers should be cautious when prescribing higher doses of fluoxetine, as they may increase the risk of seizures occurrence in susceptible individuals. Now let's discuss why the other options are incorrect. Option A and B, sertraline and fluoxetine, have seizures listed as a potential side effect. They are less frequently reported, though, compared to fluoxetine, especially at the higher dose. Option C, citalopram. Seizures are listed as a rare side effect of citalopram, and the risk does not appear to be dose-dependent to the same extent as with fluoxetine. And then option D, paroxetine. Well, paroxetine is associated with relatively low risk of causing seizures, particularly at therapeutic doses. However, caution is still advised, especially in individuals with a history of seizures or predisposing factors. Question 15. Which SSRI is associated with mild anticholinergic activity that can cause dry mouth, constipation, and sedation? Is it A, sertraline, B, fluoxetine, C, citalopram, D, paroxetine, or E, fluoxetine? The correct answer is D, paroxetine. So paroxetine is associated with mild anticholinergic activity, which can lead to side effects such as dry mouth, constipation, and sedation. Most persons taking paroxetine do not experience cholinergic adverse effects. Other SSRIs are associated with dry mouth, but this effect is not mitigated by muscarinic activity. Now let's explore the other options of why they're incorrect. First off, all the others have minimal anticholinergic activity. Option A, sertraline, that can cause some side effects such as GI disturbances and sedation, but they are typically mild, if anything. And then B, fluoxetine, that's more commonly associated with side effects such as nausea, insomnia, and GI disturbances rather than dry mouth, constipation, sedation. And then option C, citalopram, its side effects are primarily related to its serotonergic effects such as nausea, insomnia, and sexual dysfunction. And then option E, fluoxetine. Fluoxetine's side effects is more commonly related to serotonergic properties such as GI disturbances, insomnia, and activation. Question 16. What endocrine effect can SSRIs have in both men and women? A, increased testosterone levels. B, decreased estrogen levels. C, increased prolactin levels. D, decreased cortisol levels. Or E, decreased thyroid hormone levels. The answer is C, increased prolactin levels. So this is why SSRIs can have an endocrine effect in both men and women by increase in prolactin levels. Increased prolactin levels, hyperprolactemia, can result from the use of SSRI and may lead to side effects such as galactorrhea in both men and women. Breast changes are reversible, though, upon discontinuation of the drug, but this may take several months to occur. Sexual dysfunction and menstrual disturbances in women and decreased libido and erectile dysfunction in men can also occur. All right, let's go over the incorrect answers. Option A, increased testosterone levels. SSRIs are not typically associated with increased testosterone levels. In fact, some studies suggest that SSRIs may reduce testosterone levels in men, although the evidence is not conclusive at this point. Option B, decreased estrogen levels. SSRIs do not typically lead to decreased estrogen levels. While changes in estrogen levels may occur in some individuals due to various factors, such changes in appetite and weight, SSRIs themselves do not directly cause a decrease in estrogen levels. And then option D, decreased cortisol levels. SSRIs may affect cortisol levels in some individuals, but they are more commonly associated with an increase rather than a decrease in cortisol levels. SSRIs can stimulate the hypothalamic pituitary adrenal axis, leading to increased cortisol production. And then option E, decreased thyroid hormones. SSRIs are not typically associated with decreased thyroid levels. However, they may affect the thyroid function test by interfering with the metabolism of thyroid hormones, leading to alterations in thyroid function test results rather than the direct decrease in the thyroid hormone levels itself. Question 17. What is the constellation symptoms called when plasma serotonin concentrations are raised to toxic levels due to concurrent administrations of SSRIs within MAOA or lithium? Is it called A, dopamine syndrome, B, serotonin disorder, C, GABA imbalance, or D, serotonin syndrome? The answer is serotonin syndrome, option D. When plasma serotonin concentrations are raised to toxic levels due to concurrent administration of an SSRI with an MAOI or lithium, it can lead to a constellation of symptoms known as serotonin syndrome. Serotonin syndrome is a potentially life-threatening condition characterized by a spectrum of symptoms ranging from mild to severe, including agitation, confusion, hallucinations, hypothermia, tremors, muscle rigidity, sweating, rapid heart rate, and potentially seizures and coma. Treatment of serotonin syndrome consists of stopping the offending agent and starting comprehensive care. Supportive care and treatment may include nitroglycerin, cyproheptadine, methysergide, cooling blankets, chlorpromazine, dantrolene, benzodiazepines, anticonvulsants, mechanical ventilation, and paralyzing agents. Now let's go over the incorrect options. Option A, dopamine syndrome. While dopamine dysregulation can contribute to certain psychiatric disorders, dopamine syndrome is not even a recognized term in the context of serotonin toxicity. And then option B, serotonin disorder. Again, while this option contains the term serotonin, it does not accurately describe the specific constellation of symptoms associated with the toxic levels of serotonin as seen in serotonin syndrome. And then option C, GABA imbalance. GABA is an inhibitory neurotransmitter in the brain, but serotonin syndrome is not related to an imbalance of GABA. Serotonin syndrome results from excessive stimulation of serotonin receptors, not alterations in GABAergic transmission. Question 18. Which SSRI is a moderate inhibitor of CYP2D6 and can raise dizipramine and metoprolol concentrations significantly? Is it A, fluoxetine, B, sertraline, C, paroxetine, or D, escitalopram? The answer is D, escitalopram. Escitalopram, it is a commonly prescribed SSRI, and it is a moderate inhibitor of CYP2D6, an important enzyme involved in the metabolism of dizipramine and metoprolol, significantly increasing the concentrations. Elevated concentrations of these medications may result in enhanced therapeutic effects or an increased risk of adverse reactions. Question 19. Which SSRI should be initiated at 25 milligrams for the treatment of panic disorder? Is it A, sertraline, B, paroxetine, C, fluoxetine, D, vilazodone, or E, escitalopram? The correct answer is A, sertraline. For the treatment of panic disorder, sertraline is often initiated at a low dose of 25 milligrams to minimize the risk of actually provoking a panic attack. This approach is known as titration and is commonly used to improve tolerability and compliance, particularly when starting antidepressant therapy for anxiety disorders like panic disorder. To limit the GI effect, you can start the patient on 25 milligrams a day and increase to 50 milligrams after 3 weeks. Patients who do not respond after 1 to 3 weeks may benefit from a dosage increase of 50 milligrams every week up to a maximum of 200 milligrams given once a day. Sertraline can be administered in the morning or in the evening. Then administration might be better after eating to reduce any GI adverse effects. Let's go over the incorrect answers. Option B and C, paroxetine and fluoxetine. While they are effective in treating panic disorder, it's typically initiated at 10 milligrams or 20 milligrams. And then option B, vilazodone. Vilazodone is another antidepressant used in the treatment of depression and anxiety disorder, but that usually starts at 10 or 25 milligrams, not the 25. And then option E is citalopram. That started at 5 or 10 milligrams. Question 20. Which SSRI is not approved by the FDA as an antidepressant but is indicated for OCD? Is it A, fluoxetine, B, paroxetine, C, fluvoxamine, D, sertraline, or E, citalopram? The answer is C, fluvoxamine. Fluvoxamine is the only SSRI not approved by the FDA as an antidepressant. It's indicated for OCD. It's available in unscored 25 milligram tablets and scored 50 and 100 milligram tablets. The effective daily dose ranges between 50 to 300 milligrams a day. A usual starting dose is 50 milligrams once a day at bedtime for the first week, after which the dosage can be adjusted according to the adverse effects and clinical response. Dosages above 100 milligrams a day may be divided into two, thus BID. Although fluvoxamine can also be administered as a single evening dose to minimize its adverse effects, its short half-life may lead to interdose withdrawal. An extended-release formulation is available in 100 and 150 milligram dose. It must be aware that abrupt discontinuation may cause discontinuation syndrome due to its very short half-life. Let's go over the other medications. Option A, fluoxetine, that's approved by the FDA for both depression and OCD. It is one of the first-line medications for OCD and is widely used in the treatment of depression. Option B, paroxetine. Paroxetine is approved by the FDA for depression, panic disorders, social anxiety disorder, generalized anxiety disorder, and PTSD. Additionally, it is commonly prescribed off-label for OCD, although that is off-label, thus not FDA approved. And then option D, sertraline, it's FDA approved for the treatment of depression, OCD, panic disorder, social anxiety disorder, PTSD, and premenstrual dysphoric disorder. It's one of the most commonly prescribed SSRIs for OCD. And then option E, citalopram. Citalopram is approved by the FDA for the treatment of depression, but it's not specifically indicated for OCD. However, like paroxetine, it may be prescribed off-label for the treatment of OCD. Question 21. Which SSRI should be taken with food to avoid inadequate drug concentration? Is it A, vilazodone, B, paroxetine, C, fluoxetine, or D, sertraline? The answer is A, vilazodone. Vilazodone, it is an SSRI that should be taken with food to avoid inadequate drug concentration. Taking vilazodone with food helps improve its absorption and ensure adequate drug concentration in the bloodstream, enhancing its effectiveness in treating depression and anxiety disorders. This recommendation is included in prescribing information for vilazodone to optimize its pharmacokinetics and therapeutic outcomes. All the other options can be taken with or without food, and food intake does not specifically impact its absorption or efficacy. Therefore, it's not specifically indicated to be taken with food to avoid inadequate drug concentration. Question 22. What is a term for the phenomenon where patients experience a diminished response or total loss of responses to SSRIs? Is it A, tolerance, B, dependence, C, breakthrough, D, poop out, E, withdrawal? The answer is D, poop out. So poop out, that is a phenomenon also referred as antidepressant treatment failure. It occurs when individuals who initially respond well to an SSRI begin to experience a reduction in therapeutic effectiveness over time, despite ongoing treatment at the same dosage. Poop out can be frustrating for patients and clinicians and may necessitate changes in medication and or treatment approaches. Question 23. Which SSRI should be tapered gradually to limit symptoms of abrupt discontinuation syndrome? Is it A, fluoxetine, B, sertraline, C, paroxetine, D, citalopram, or E, phalazodone? The answer is C, paroxetine. Paroxetine is the SSRI that should be tapered gradually to limit the symptoms of abrupt discontinuation. Abruptly stop in paroxetine can lead to withdrawal symptoms, also known as discontinuation syndrome, which kind of feel like the flu-like symptoms. Might complain of dizziness, nausea, headaches, irritability, insomnia, and sensory disturbances. Gradually tapering the dosage of paroxetine under the guidance of a healthcare provider can help minimize the risk and severity of these withdrawal symptoms. Now let's go over the other options that were incorrect. Option A, fluoxetine. Fluoxetine has a long half-life, which makes it less likely to cause withdrawal symptoms upon abrupt discontinuation compared to other SSRIs. However, it is still advisable to taper fluoxetine gradually, especially in individuals who have been taking it for an extended period. And then option B, sertraline. Sertraline generally has a shorter half-life compared to paroxetine, but it can still cause withdrawal symptoms if discontinued abruptly. And then option D, citalopram. It has a relatively long half-life and is less likely to cause withdrawal symptoms compared to shorter-acting SSRIs. And then option E, phalazodone. That has a relatively short half-life, and so abrupt discontinuation can lead to withdrawal symptoms. Again, you want to taper this drug too. Question 24. Which SSRI has no additional benefit when the dosage is increased from 10 milligrams a day to 20? Is it A, citalopram, B, sertraline, C, fluoxetine, or D, phalazodone? The answer is A, citalopram. Citalopram, when increased from 10 milligrams a day to 20 milligrams a day, does not consistently provide additional benefits in terms of efficacy for the treatment of depression or anxiety disorders. Clinical studies have shown that the therapeutic response to citalopram may plateau or even reach a maximum effect at a lower dose of 10 milligrams a day, with minimal additional benefit observed with higher doses. All right, now let's explore the other options of why they're incorrect. Option B, sertraline. Increasing the dosage of sertraline from 50 milligrams to 100 milligrams is common practice and may provide additional benefits for some patients, especially those with depression or anxiety disorder who have not achieved or an adequate response at the lower dose. Therefore, sertraline is not correct. Option C, fluoxetine. Similar to sertraline, increasing the dosage from 20 to 40 may actually provide additional benefits for some individuals, especially those that are having treatment-resistant depression or other psychiatric conditions. And then D, phalazodone. That is a relatively new antidepressant, and while increasing the dosage may provide additional benefit for some patients, it's not a SSRI mentioned in the question as having no additional benefit at the higher dose. Alrighty, all done. Hope you enjoyed this. Go ahead and click on the next video on other antidepressant medications. Thanks.